usually via telemedicine. So I do see people in Europe, East Coast, all kinds of different places. So some background, because to give you my credentials so you kind of know who I am, and I'm not just some neurologist out there. So I am what they call board certified in headache medicine by the United Council of Neurological Subspecialties. They're a very specific certification, and we do have to take obviously examinations to maintain our program. I'm a fellow for the American Headache Society, and I'm a member of the International Headache Society, and I give lectures all the time. I came out of UC Davis, and I did my headache and pain fellowship at UC Davis, and that was actually sponsored by the American Headache Society. And for a while, I did work at Kaiser Permanente, and I was what they certified their headache champion. They only had a handful of headache champions in Southern California, and I was one of them. And then now I work in Mission Viejo, and then been here since 2008. So when I was at Kaiser Permanente, we actually used to do a headache seminar routinely on a weekly basis, preceding the appointments with me and my nurse practitioner. That way, a lot of information was provided before the actual appointment. So really quick to disclaimer, Ms. Purnell, my voice is not terrific. I did have a bout of COVID-19, and it damaged my vocal cords through the process. So it's still healing. So it does sound a little hoarse at times, and I apologize if it's not coming off very clear.
You sound good on my end.
So you might see this slide deck. I'm going to toggle between a couple of slide decks. And this is what's really important. Headache is a very common problem. And it says here that current statistics show that 36 million people in the United States have a migraine disorder. So those who have headaches, we're not alone. I have them. Numerous people in my office have them. And 1 out of 4 households has someone with a chronic headache disorder. It doesn't necessarily have to be migraine, but a headache disorder. Unfortunately, the majority of headaches are more in female than male population, but it's not far off. The statistics are ever evolving. And according to the World Health Organization, migraine and headaches are one of the most common disabling disorders in the entire world. 14% of our current population of people do suffer from chronic daily headaches. So it is a very costly disorder. You can see here that people who have to call out of work due to headaches is costing our economy $13 billion every year, either in missed work or expenses related to help cover the care costs of people with headache disorders. Now, this is a far cry from many other conditions, mainly like diabetes and things like that, but you can see that basically the statistics are trying to show you that headache is not something to just blow off. And unfortunately, those who do not have headaches, and even if you do have a headache, you look okay, right? You don't, there's nothing really obvious to see with somebody in pain. So unfortunately, when it comes to people around you, they really can't understand the suffering that you might experience. Depression is very high in those with frequent headache attacks, and our children who do have headaches are often underdiagnosed, and if they're underdiagnosed, they're also undertreated. I don't know how many under 18 individuals we have on the video. I do see pediatric individuals, and in fact, I just saw a recent person in high school, and basically the high school nurse was not really giving in to any accommodations because the high school nurse didn't really believe migraine is a disabling problem. So it is a difficult thing. But ultimately, most of our research in headaches are about migraine. And the reason is because headaches is a very complicated condition, and migraine is the prototypical condition for many of our headache disorders. There are what we call primary headaches, and primary headaches are conditions where there's no reason other than the fact that you are a headache sufferer. Okay, I need to make this very clear for many individuals, because everybody always comes to us and say, I want to know why I have migraine, or I want to find a cause for my migraine. But according to the International Headache Diagnostics for Headache Care, migraine, cluster headache, tension headache, and many other headaches, which I'm not going to have a lot of time to go into, are what we call primary. And primary essentially is there's no cause. You are a headache sufferer, and you are sensitive to having headaches. And many of those with primary headache disorders are genetic, meaning other family members will also have headaches. To say that I've got to find a cause can often lead people down a very frustrating cycle of assessments and unhappiness, because they're on this ever-ending quest to say, I've got to know why I have them, without getting appropriate care and treatment to try to address the symptoms. So what that means is it's like saying, okay, I'll throw myself, I have asthma. Why do I have asthma? I don't, it kind of is a moot point. I've had asthma since I was a little kid. And just because if I could find out why, it doesn't necessarily mean it's going to take care of itself. So that's why we look to see if there are other factors involved with your headache. But as you see, 36 million people in the United States with migraine, 36 million people do not have something happening to them that's giving them their migraine. So very commonly people will say, I'm worried I have a tumor. I've had headaches for, I've had people come in, they're like 60 years old, 70 years old, even 40 years old. They say, I've had headaches since the age of 8. I'm worried about brain tumor. They don't have a brain tumor, okay? And for decades, and nobody's ever realized it. But if there's some concerns, we always get a scan, and most of us probably had a brain scan sometime in our career of having these headaches. So it's really important to understand what primary means. Secondary headache means there is a particular reason why the headaches came on. And that could be a prior history of a head trauma. You never had headaches, but now you do because you had a concussion. I have patients in the hospital who come in with meningitis. Of course, they have a headache secondary to meningitis. So those are clear-cut reasons, and sometimes it's not always obvious, okay? So some patients may have a secondary headache problem because of something happening in them, like they didn't know they have a thyroid disorder, and their thyroid hormones are, the thyroid tests are abnormal, and they're having headaches because of the thyroid being over or underactive. So that's what I'm mentioning. So that's why this slide is saying that headaches are very complicated. They're not simple. They're not a pain problem. Headache is not just a pain disorder. So to look at headaches as simply a pain problem is only addressing half the problem. Because we do know, as it says right here, that headache is an actual disease process of the nervous system. And there's many factors involved. And this slide here will show you that there are changes in our brain. You can see the word activation and hyperexcitability and neuron episodes and changes in our blood flow. These are changes that happen in our headaches before we even get pain. Usually pain just doesn't do that. And when you look at this brain scan here, you see these little red dots. This is actually this is a very old picture of a person having a migraine in a very highly specialized brain scan. And we see in the brain where these changes actually develop and occur. It is happening in the brain first before any pain. This slide might be very complicated, but this is a actual MRI. It's a special type of MRI, and you can see the disturbances happening during their migraine aura, if an aura were to occur. There are blood vessel changes. There are inflammation occurring within the blood vessels, and the pain phase of our headache usually indicates that there's expansion and dilation of our vessels that lead to inflammation around our head. So it is a very unusual condition, and that's what all these slides are saying, that if you look at the MRI, if you look at headache by and large, and migraine being the prototypical, you have all these disturbances in the brain. Eventually, if you do, may feel pain. But again, I stress this, migraine does not translate as to a pain disorder. You can have migraine headaches without any headache. And that's what we call migraine without pain. It's a very unusual thing. If you ever been to my office, you're going to see my office adorned with Alice in Wonderland, and people think maybe I'm a kid at heart, maybe I see kids, maybe I'm just kooky that way, but actually it's not that, because all of the 20 years of studying migraine, I've been fascinated with a phenomenon called the Alice in Wonderland syndrome, and it's an actual disorder of the brain where people do see hallucinations and visual disturbances that correlate with what was written by Lewis Carroll, because Lewis Carroll himself did suffer from migraine headaches as described in his diaries. So many of these effects that we saw do occur in migraine. So this was one of his early pictures in 1855 describing something before he wrote the book about what he saw visually in his attacks. This is a picture that some people may describe as a scotoma. This is a blind spot that triggers out during a migraine episode and may enlarge and move and even spread out or shimmer during the actual attack. So we've done a lot of studying about Alice in Wonderland and other literary works, but people don't understand that migraine is a very complicated condition. In fact, in ancient Egyptian papyrus, way back like 5000 BC, there are descriptions of migraine-like headaches. So it is unfortunately, a very old disorder. Okay. So people may get visual aura, which is a disturbance, and there are genetics involved, and these are just a handful of some of the identified genes in our pool to promote or increase the likelihood of us having headaches. Not everybody will have these, okay? So migraine characteristically is the way a headache actually feels, okay? Does it feel a certain way? So coming back to the description, I don't have the criteria right now, but people will say, well, what does a typical migraine feel like? Okay, so I'm coming to this slide. The bedside diagnosis of a migraine is a migraine in an adult must last for at least 4 hours and can be for several days. 3 days is about the hallmark. Throbbing, causing insensitivity to light or sound. Nauseating, often impairs your ability to function or work. That kind of separates you from a tension headaches, because majority of patients with tension headaches may still be able to work and function with the headaches, but usually tension headaches do not induce a significant amount of nausea. Okay. So I know like most of you don't just have migraine. Many of you may not just have tension headaches. You may have a mixture of attacks, different types of headaches. And that's going to be necessary for individual care to see, well, what is it that you are experiencing? But if we stick to migraines, I'm going to go through some very specific treatment here. Let me pull this up on this slide deck here. Okay. So acute treatment. Okay, so when we talk about headache management, the first thing that everybody, when they seek medication, I have to describe a couple of different things. There is what we call rescue therapy. Rescue therapy is a treatment that you take when you have a headache versus chronic preventive therapy. That is something that you will routinely take or have to do to control the headaches and reduce the number of frequency of headache attacks and pattern of headaches. So acute therapy or rescue therapy, this is pretty obvious. When a person has a headache or any pain, let's say a headache, we're going to talk about headaches. We're going to talk a little bit specific about migraine. Let's say you have a migraine headache. Rescue therapy is, I gotta take something to get rid of the headache at this time because it's too annoying, it's too bad. So that's rescue therapy. Rescue therapy, over-the-counter, many people will use over-the-counter medicines first and foremost because that is readily available. You're talking about your ibuprofen, Motrin, Advil, Excedrin compounds, things that are over-the-counter to take for pain. But those who actually go and seek medical attention for their headaches may get specific drug therapy. And so I'll get to the top treatments that we have available. So this here are the common medicines. It says here triptan therapy is the first line treatment. It is a prescription medication, okay? And I'll talk about this particular medicine, and probably many of you have been given this kind of medication, and I'll tell you how they work. But others include non-steroidal anti-inflammatories. Ergotamines are very old drugs that are not used as much anymore. Some of you, not you particularly, many people may be given this prescription here called Butalbital. And the trade name is Furanol and Furacet. And I'm only going to make one very quick statement about Butalbital. For us who treat chronic headaches, this drug is one of the worst drugs in headache medicine to be continuously taking. And people don't understand that. But the drug came out in the 1970s, like 40 years ago, for tension headaches. It was not a good treatment for tension headaches. It actually has no trial to ever prove that it is helpful long-term for migraine headaches. And the American Board of Internal Medicine, that's this, and the American Academy of Neurology in 2013 says, please do not use this drug. So unfortunately, when I see people in my clinic and they're on Butalbital, that's one of the first treatments that I tell them they have to stop, because I no longer use this treatment at all. I've not prescribed Butalbital since 1999, and I'm not ever going to restart it. So, and again, when I worked at Kaiser Permanente and early on, I had to treat people and detox them off certain medications to help their chronic pain. And Butalbital was one of the most common drugs I had to detox people off because of its habit-forming properties. And people don't know what it is. What is Butalbital? It is not a pain reliever. It's actually a sedative. It is actually a tranquilizer. But those who may have tried triptans say, well, what is a triptan? I've been given triptans. What are they called? Sumatriptan, rizatriptan, naratriptan, zolmitriptan, elatriptan, almotriptan, frobatriptan. These are not pain relievers. They actually do not work on pain receptors. They are what we call agonists, which means they activate very specific serotonin receptors. They do not raise your serotonin levels. Okay. So on the B receptor, the blood vessels that are dilated and expanded and causing inflammation and discomfort and pain, by activating that receptor, the blood vessels do return to normal, a normal size. And on the D receptor, because of all that inflammation happening due to the headache attack, by activating the D receptor, all these chemicals that cause inflammation reduce down. And these medicines treat the entirety of the headache. So they treat pain, the pain will reduce. It also treats nausea. It also treats sensitivity to light and sound. And often patients are able to recover fairly quickly, hopefully, to at least get some sense about what's going on. And then you see this one red here called CGRP. And that's really important because that's going to segue into what CGRP is. Okay. CGRP stands for calcitonin gene-related peptide. And it does have a role in triggering or promoting the migraine headache to keep occurring. It gives you that pain. We find it in the central nervous system, particularly the brain. It is present in other areas of the body, but not so much as in the pain. So when you get a migraine, this CGRP is very much active and can cause a lot of pain. It's probably and is active in other headache-related phenomena. So those that may try it, and those who watch television may see commercials. All these new commercials for these new treatments of migraine, there are all injections, okay? There's Aimovig, there's Emgality, there's Ajovy, there's Vyepti. You may have heard about these medications. These are most of them are 1 time per month self-injections with a needle. And using monoclonal antibody therapy, you injected these large monoclonal antibody neutralize the CGRP property and headaches get more control. These injections are what we call preventive treatment. Okay, preventive treatment, as I mentioned earlier, is something you have to do routinely to better control the number of headaches you might get or the severity and pattern of the headaches to reduce them down. These are not rescue therapy. There are these drugs here called Gepants, okay? And these are pills, and you may see them on television as well. These are pills. Qulipta right here is unique because it is only for preventive therapy. It's a 1 tablet per day preventive option. Ubrelvy is only for as needed rescue therapy. It's just like a triptan or ibuprofen. You take it when you need it. Nurtec is unique because it can be used similar to Ubrelvy, meaning for rescue therapy. But Nurtec can also be used as a preventive, similar to Qulipta, by taking it every other day. Okay, so these have been out for a couple of years. They're fairly new in their care. So when you have a headache, you have to consider some type of acute treatment. And then for chronic headache preventive options, it is something you're going to do routinely. So the Cgrp inhibitors, as you see here on the bottom, these are not the only drugs available for preventive, and they are fairly costly. So for many, many decades, traditionally we have used numerous pills, oral tablets that are seen in other classes, from medicines that are used to treat hypertension or high blood pressure, such as propranolol. Many different types of antidepressants have been very effective. Anticonvulsant therapy, with topiramate being a very common drug due to its favorable side effect profile compared to other medicines. Different types of antihistamines, anti-inflammatories, even a specialized drug here called memantine, which is used for Alzheimer's, has been shown to help chronic migraine. And then, of course, botulinum toxin or Botox, okay? Now, I hate to be devil's advocate because everybody wants something maybe they haven't tried or they heard something is the best. Many people believe that these drugs on the bottom, like Botox and the Cgrp inhibitors, are the treatment. They are reserved for a reason, like they're the big gun, and then that's not actually true. There's been no specific head-to-head study to show that Botox or using Cgrp inhibitors are better or more superior than topiramate or propranolol. They're just another treatment in the arsenal that we have available. So I'm going to digress a little bit because when I bring up cost, I'm not trying to not give you the best treatment. I do try to cater people's treatment to what might be ideal for them. But it would be negligent of me to not discuss cost because we are not made of money. I'm not made of money, and treatment can get very expensive. And so effective medicine like topiramate is very effective. You go to your pharmacy, you get a 90-day supply of tablets. It helps control your migraines. It's only about $10 for how much you pay for it. If you break down the Cgrp inhibitors, like this drug right here, Ajovy or Emgality, each shot is $600. And Botox is about $1,000 per month. But you get Botox every 3 months. So, you know, someone might spend anywhere from $2,500 to $4,000 for their treatment. So they are costly. And if I said Botox is not necessarily better than topiramate, but it is definitely more expensive than topiramate. So we always like to see if health plans will authorize your treatment. And I don't set the rules. If I could offer Botox to everybody, I would. But of course, we pay our health plan for a certain reason. So health plans do set their own rules. They know all of these medicines are available. They know they're all effective. So they have set up their own lifeline. So if I went to somebody and said, I have chronic headaches and I want some treatment, the doctor can say, do you want Botox? The health plan won't authorize Botox as your first line drug because of its cost without having tried other very effective medications that are less costly overall. You know, unfortunately, healthcare, your insurance is a business too. So if everybody could get Botox, probably everybody would, but there are some hoops. And again, for me and my physician colleagues who've been treating you long term, we don't always set the rules. So we do what we can and we try where we can to try and get these under control. So so preventive options are necessary. So to go back to this slide deck here. Okay. So whenever you're given a treatment, you want to treat each headache as early as possible. Unless you get them every day, then you have to kind of be a little more choosy. And we want to be very specific in our kinds of options and treatments to try to control the headache attack. The United States does have a headache consortium. We've been trying to guide practitioners and the public about how to treat headaches. So number one is to educate. And this is what this conference here is about. It's to educate you about different types of headaches. I haven't gone into other types of headaches yet, but to understand the headache condition. It's not just about giving a drug or a treatment, okay? Use very specific medications if possible, because many of the drugs like opiate drugs or narcotics or Butalbital, they are highly more likely and can be potentially harmful for you because they can give you what we call medication overuse, which means you have more and more headaches because of the fact that you're treating yourself with numerous different pain relievers. Medication overuse is a real problem in and around the world. And majority of people had migraine as their initial headache versus tension type headache or other. And some simple guidelines is you might be in a rebound headache if you're taking a number of drugs routinely. Okay, triptans are less likely to get a rebound effect. So going back to Butalbital, which is Furanol and Furoset, my physician partners in Germany and the Eastern countries there, they completely banned Butalbital, which is Furanol and Furoset, from their country, their drug. So it's contraband in some of these countries due to the fact of overuse. And studies have shown that when they banned the drug, they actually saw a reduction statistically in medication overuse headache. It was very, very clear call. In 2004, Butalbital and Furanol Furoset was going to be banned from the United States, but it is difficult to remove some drugs unless they've proven significant harm. But if you are experiencing frequent headaches, we need to look if you're taking too many medications, understand your triggers. Triggers is key. Triggers are not causes. So people say, well, what is a trigger? Because many people say my cause of my migraines is that I might drink too much caffeine. It's not necessarily a trigger unless it's very clear that you never get headaches otherwise. Triggers is something that happens or something you do that promotes you to have a headache at the time. Triggers could be something you eat, something you drink, weather, going up in an airplane. These are things that give you the headache. So for me, I get a lot of migraines when I fly. If I get on an airplane, that's one of my big triggers. Some people it's weather. I had an individual who always gets headaches when they're in London, but never when they're in Los Angeles. They have a very clear weather influence. And that's why it might be seen more commonly in female individuals or women as opposed to our male counterparts because of the hormone influence that may have to endure and experience with disturbances and changes in estrogen. But even though estrogen is a potent trigger, taking estrogen tablets doesn't necessarily stop them, but may help control to some degree. But not everybody should be using hormone therapy just because of headaches. Goals of preventive is always to reduce, and improve. So they can reduce the frequency, severity, and duration of each attack. And even your acute therapy, the treatment you take for rescue, might be better, might get a better response. So who gets a preventive? And many of the individuals I do see never been on a preventive option, even though they may be getting lots and lots of headaches. So prevention can be offered to any type of headache condition, depending on how many you get. So if you are getting 3 or more headaches episodes per month, maybe 6 to 10, you may want to consider a preventive option. Okay. And we always start low and titrate depending on the medication of choice. Okay. So I'm not going to go through all those. Specifically, again, I'm not going to ask who's gone on Botox, and people say, oh, how do we even stumble upon Botox? And why does Botox even work? Because nobody really understands Botox and headaches. Certainly, we're having more and more clinical data over the last 20 years that's showing how Botox actually works for chronic preventive therapy. It is only FDA approved in the United States for migraine. It is not approved for tension headaches. So this is a very busy slide, but we have seen numerous peripheral and central effects to our nervous system on how Botox will help reduce this little part here, inhibit central sensitization. That is the key word right there and how it helps headaches. But it's funny that neurologists were not the ones that stumbled upon it, even though we've been using some form of Botox therapy since the 1980s. But we didn't discover the pain effects. It was an individual doctor who was mostly involved with dermatology and plastics who was treating a number of people with pain disorders and found that Botox was effective. And studies have actually accurately proven its facts. So Botox is pretty well established as a treatment. I want to change a little bit of gear from the migraine. Cluster headache is most commonly in men. These are very severe headaches. And I do meet individuals who say they have cluster migraine. Based on the international criteria, there is no cluster migraine. That's, I don't know how that term came about or how people came upon it, but cluster headaches are very specific and unique headaches that are much different than migraine. Certainly a person can have both types, but it is rare. And tension headaches are very severe. They're very brief headache attacks. Usually each headache itself is no more than 3 hours and completely goes away. But you can have a number of these headaches in any given day. And that's why they're called cluster. There are very specific seasonal and weather patterns and night and day patterns to developing this headache. It is strictly one-sided. Okay, so it's only going to be on the right or it's only going to be on the left. Migraine can be on the right or left or even both sides. And those who may not know, migraine, the word itself, migraine, means one-sided in the old texts. It is short from the word hemicrania, which means one-sided. But the most common headache overall is not your migraineurs, is not your cluster sufferers, it's your tension headache sufferers. These are the most common headaches. Okay, they're often squeezing, vice-like muscular pressure, achy, and they can just gnaw at you for hours. Pure tension, there's no reason for it. You just get that muscle tension and it causes the pain. But there are secondary reasons, like people do have and may have significant neck problems. But tension headaches are not always a neck disorder. So it's important to know. And many people will say, well, I have a herniated disc and that's why I have a headache. And that may be true, but it may not be, because I see people of all age groups, and I tell you, if it were true to say that a herniated disc is the cause for all this pain, then majority of people should have pain, because herniated discs are very common as we get older. If I do an MRI on almost anybody over the age of 50, I'm going to find a herniated disc, and by far majority of them do not have pain or headaches. So it is not a disc problem. It's not necessarily a spine disorder, but that the headaches do drive out from that tension and coming up from the neck. Okay, like I said, for female and headache, it's much more common. There's a significant change in our hormones. Estrogen is the key component right there. Okay, we treat them similarly. We use many different types of treatment, but birth control or hormone therapy is not, we should not rely on it specifically as the treatment, because it's been very variable and unpredictable. Okay, and as you heard me here, children are under-recognized, and many kids may experience many different types of headaches beyond just migraine. And you got to have a keen eye and ear to kind of hear their symptoms, because children do have a very difficult time telling us how you feel. So there are other headache types and everything we need to exclude. Secondary headaches, obviously there's a tumor or a mass or something. Certainly that's a secondary headache. It's not a primary headache, but many of these are primary headaches. This is a primary headache disorder. This is a primary headache disorder. This is a primary, you may not understand all these headaches, but we really do want to make certain that there is not a secondary reason. So ultimately, we need to just make a very effective diagnosis. Majority of the time, we diagnose and can come up with a very effective treatment plan based on the history and physical. No other imaging is really required. And it's actually dissuaded. We don't really promote brain imaging on people who has a chronic headache disorder And we mean like some people, like I mentioned earlier in the broadcast, some people come into me, they have headaches for 20 years. Nothing has changed in any sort of way with their headache quality, no new symptoms, nothing. They're perfectly functional. They work every day, or they have, and they go, all of a sudden they want a brain scan because they're worried about something. And although there is true, you're going to hear those cases where we did find something, but that something may not even be related to why they have the headaches. And many people go, well, I want to rule out I have a tumor. Well, tumors, headache and pain is not the most common symptom related to a tumor. In fact, if you're relying on pain to diagnose a tumor, you're only going to diagnose probably 1 out of 10 people. So pain is not a classic hallmark symptom when it comes to a tumor. People say, I want to know about an aneurysm. Okay, I want to find out about an aneurysm. It's true, people who have chronic headaches, we may see aneurysm. Even some people who had a ruptured aneurysm and they were told they have a history of migraines, they may be completely, and most often are, unrelated, because aneurysms don't give symptoms until something happens to the aneurysm. So if you look up Mayo Clinic or say, what are symptoms of an aneurysm, they're going to tell you, unless something happens in the aneurysm, there are no symptoms. You wouldn't know. For some fun facts, this is a picture of Zeus. And you say, it's funny because Zeus had headaches. You say, why does Zeus have headaches? So this story is Zeus experienced significant bad headache attacks. Okay, so Ares cleaved Zeus's head with an axe, and Athena popped out. So that was some fun fact there in regard to the birth of Athena. Okay. So I don't want to take up the entire hour. So I can go on and on and on about headaches. I mean, really, there's so much interesting things about headaches, new data, but I want to introduce you to like the newest medication and the tried and true medication and what they really all mean. But the one thing is you don't just give up. You just don't say, well, I've lived with these things and these are the only things that work. And that does make it difficult. And certainly you might be on a treatment and that is the only thing that does work. And usually I'm able to find something else. Many people said, I tried everything. And then I say, well, write everything down because I bet there is something that you haven't tried or heard. So it is very important to go through the history and physical and all of that. So we have about 15 minutes, and that gives me some time that if I didn't say something, I want to address it now, and it might take some time too. I'm going to turn my video off because I need a little drink of water. I don't want you to see me drinking.
Thank you, Dr. G. That was very cool. I didn't know some of that stuff.